So anyways, what are you particularly worried about, Nicole? Just getting it done?
Yeah, I just feel like it's kind of like two big assessments in one day. That's really it.
So what we did was, this is how I did it. This is what Mrs. Gifford told us to do was we did, people signed up for the cath, the urinary catheter. While I was signing them off, they worked in groups and videotaped the NG tube insertions.
Oh, okay. So it's still NG Tube is going to be done on campus, but we're still taking a video and uploading it. We're not getting signed off on that like live.
Correct. That's how I did it. That's
Okay.
what I was told by Mrs. Gifford, because the urinary cath one is really one that we want to see you guys do. And I know you guys want to get that, down. I have to be honest, we ended up having to, people started and then we kind of work, the way I did it, I let them work through it and then we kind of went back and redid it. Took a little bit of time, but I think everyone overall did pretty well. Right, Lynn? Don't you think?
Yeah.
Yeah.
This TORP is really helpful too.
So, well, I want you guys, I know this is a big thing. And I, as I watched y'all do it, I just think how important it would be to have just a couple of days in a row that you could just come in and I don't know, I'm thinking of different ways. I don't know if it's before next semester or at the end of this semester and just have you guys have stations and just work through these. My thought is urinary catheter, work through the assessments again. What do you guys think? I don't know. I'm just thinking outside the box. It's not really for me to decide, but so I'm imagine you guys all pretty much want to start with the case study, right? Okay. So because I feel silly looking at my own face here. Just to let you all know, this is my bedroom. That's why I'm not going to show you my bedroom through this whole thing. So let me put on, Nicole, does that make you feel any better?
What part?
About how we're going to do it? How we're going to.
I just think, I don't know, it's hard to like practice. I know we're supposed to practice those on our own before we come in. It's just those are like especially hard to practice on without a dummy.
Exactly.
Whereas like when we were on campus for a little bit last semester, we actually had time in the sim lab to practice.
Right.
Whereas like with this, I feel like when I show up, I'm like actually just really doing it for the first time as I'm getting signed off.
Yeah. Yeah, that happened a little bit. I could tell last night or yesterday.
It was helpful if you what I did was to try to open the catheter, so I familiarize myself which one goes first, and then watching the video as opening the package.
Yeah, don't open. You have two of them, right?
Yeah, well, I just opened it just to like practice
Oh,
the
no,
other.
I didn't mean anything bad. I'm just saying at least leave one, because I really think leaving one
Yeah.
virgin, quote unquote, one that you can open in front of us while you're testing. I think that works better than trying to like put one back together and then the gloves don't come out right. And then the stuff isn't layered like it usually is. I thought the ATI video was pretty good. It didn't get into a lot of extra stuff. The only thing I didn't see her doing in it was doing wiping the perineum before she even started. I didn't see her do that, did she? Or did I just miss it? She just went right in and did the catheter. on your competency, it talks about wiping the perineum and stuff like that. Is what you would do in the hospital. You would clean someone up first before you start to do the, position her and do the catheter. And say her, because that's what you'll do. You're not going to do a male. This will be a female insertion. And then we just, at the end, I just said, okay, put the mannequin back together, and then you took it out. So we did both. You inserted it and took it out. And I didn't get to see anyone doing the NG tubes. You guys all had it done by the time I got everyone signed off. So, okay. So you want to start on, do you have your case study pulled out, guys? Okay. All right. So Claudia, do you want to start? Do you want to start with the reading?
Sure. You are home. You are a home health nurse seeing for the first time PC. Let me start over. You are a home health nurse seeing for the first time PC, a 64-year-old divorcee diagnosed with small cell lung cancer about 1 year ago. PC was treated with radiation and chemotherapy. However, her oncologist recently informed her that her cancer is not curable because it has spread to her bones and liver. The focus of her treatment will now be primarily palliative.
Palliative.
Palliative. She is confused and somewhat bewildered. She vaguely remembers the term, oh my God, you just said the word, palliative treatment from the discussion of her situation with her oncologist, but she doesn't know what it means. Question 1 asks, how would you describe palliative treatment? I think it's like end of care, like just so everything goes smooth. Like, I don't know, I can't explain it.
So,
it's like end of care. I don't know.
So let me just start by, because as I read through this particular case study, I feel like it doesn't quite it's not really how we want palliative care to be today. The hope is, the way I think of palliative care is it's a spectrum, right? In Giddens' book, it talks about it being, it's actually a spectrum with hospice and end of life care at the end of it, right? So in this particular case, PC was diagnosed with the cancer a year ago. So at that point, I mean, well, I guess because the cancer they thought at first might have been curable is why they didn't put her to palliative care. When a person has a medical diagnosis that's not curable. So when you think about that, that's not just cancer, that's COPD, congestive heart failure, cancer. Do you see what I mean? So those are so someone with COPD could be diagnosed with that, but they actually live with that they could live 4 or 5 years with COPD. So, but they still could be in palliative care. Does that make sense?
So the way that Giddens basically words it is that palliative treatment is care that focuses on the symptoms of disease early on, helping patients with chronic or life-threatening diseases to manage their pain, symptoms, and to treat or prevent the psychological, social, and spiritual problems that are related to that diagnosis.
Yes, exactly. So you can see how much of a benefit this would be, and how I kind of took it, and as I read more on palliative care over the year or so, but is that it's kind of also another way that we can get insurance companies to pay for some of this stuff, right? Because insurance companies, once you go to hospice care, Medicare or whoever picks up all of that care for hospice, but you don't go to hospice care until you're like 6 months, you have a 6-month diagnosis, right? I mean, typically that's kind of the rule of thumb. So, but there's a lot of care that needs to be given to someone who's living with a diagnosis that basically is not curable. Does that make sense? And like you said, Nicole, I mean, read that again, Nicole, because that is perfect what they had in there.
So palliative treatment is the care that focuses on the symptoms of disease early on and helping patients with chronic or life-threatening diseases to manage their pain, symptoms, and to treat or prevent the psychological, social, and spiritual problems that are related to that diagnosis.
Good. Does that make sense, everyone?
Yes.
Yes, it does.
Yeah. Any questions? No? Claudia's okay. So Claudia, could you put it in your own words now? How would you describe to her what it was, or anyone can do? Nicole gave us from the book, but how would you describe it to PC now? Oh, you're on mute.
Oh, I said if someone could help me, I'd appreciate it.
So kind of, would we say that we can say it's we are going to manage your symptoms and the pain as much as we possible as much as we can, Miss Thor?
Yeah, so that would be good to include, right? To really describe what that means. So she's going to be dealing with anxiety. She's probably not going to be eating well because she might be depressed. So you want to teach her about nutrition, or maybe part of the team that for palliative care would be a nutritionist. You want to help her, like you said, with pain control, in that just to have her understand that at this point, the doctor has said, and you understand that it is not a curable situation that you're in, a disease that you have. However, that doesn't mean that we can't make you comfortable, provide you with care, and improve your quality of life. And possibly improve her quantity of life, right?
Right.
So what, Crystal, so what kind of assessment do you need to perform, or Virginia, whoever wants to take a stab at that?
Are we on number 2 now?
Yeah.
Oh, I can go ahead and say what I wrote. So
Okay.
I said that you're gonna start off with recording her medical diagnosis and note any allergies that she has, because depending on like the medications that she's on, you want to make sure she doesn't have a bad reaction. You'll
Okay.
determine if she has already done any advance planning or filled out legal documents like an advance directive or living will, and if she hasn't, kind of talk to her about that and see how she wants to approach that.
Good, yeah.
Assess any signs and symptoms of the disorder that she has, and then also any discomfort, pain, nausea, or dyspnea. Perform a functional assessment to determine her ability to participate in ADLs, and if she's not able to, you might refer her to like a physical therapist or like a volunteer to help out with that.
Okay,
Assess her ability to cope with her diagnosis and establish who her support system is, and then also assess any significant social or spiritual concerns that may be related to this alteration in health.
good. How, yeah, so how is she in this? That's really good, Nicole. She pretty much hit on every single thing that they have on this. So how is she responding to the stress of her terminal illness? Get her to talk about it. Very important, talk to her about advanced directives, right? Who is her support system? Is there someone that she wants to have as, oh God, what is the power of attorney? Just, and it would, the sooner you bring this kind of stuff up to a person when they're still able to deal with this, don't you all think it is better? I mean, to know exactly what that person wants than to wait till the person is, a week from passing and now they're telling you, oh, they want this or that. I mean, this is the time we know that this person has a non-curable medical diagnosis. So good, Nicole, that's good. It's really good. Anyone have anything else they want to add? And Nicole put the definition for Giddens on the page number. It's page 497. Okay. Lynn, do you want to do number 3?
Okay. Palliative care is delivered by an interprofessional team. What team members would likely be involved in PC's care and how?
Okay, what do you guys think?
Nurses?
Okay, but think about what we just talked about, all the things that we, as the palliative care team, that we want to bring to this patient. What kind of people would that be? What kind of specialty areas?
For ADLs, maybe occupational therapists, physical therapists,
Yeah, good. That's 1 or 2.
social worker,
Social worker, good.
or like coordinating resources.
Yes, perfect.
Physical therapists to help with musculoskeletal function and maintain her mobility.
Okay, so what about nutrition?
Yes, dietitian.
A dietitian would be good, right? Do an assessment, see what kind of help her set up some sort of give her information on what kind of vitamins would be good, maybe stuff that wouldn't be helpful. Assess swallowing, that's a big one. But usually occupational therapy would do the actual swallow assessment. But yeah, the dietitian then could come up with the food. Who would take care of medications?
Pharmacist or prescription
Pharmacist.
doctor.
Yep. Pharmacist. And then how about spiritual?
The chaplain or clergy.
Good. Yep. And they mentioned something, and this is would be nice, is just someone, they have volunteers here, but just someone who is available to maybe come over and sit with her for a while. Maybe she lives with her. I don't know. They didn't say who she lives by herself or. So at this point, all we know is that the home health nurse, I think she lives by herself right now.
She's a divorcee.
Yeah. So maybe seeing if there's anybody that would come over to the house and, you know, help her cook dinner, maybe give a visit with her, some sort of respite for any caregivers that are there with her. Like if maybe she ends up moving in with, we don't know much about her, but some of her family, but that caregiver, again, we talked about that last week, would need respite, right? So that person would be part of the team.
Would
So
RT be one too?
RT, I would have to say I don't think so at this point. Now, if you're thinking in terms of like a COPD patient that maybe is the palliative team come visit them and the person is on O2, I don't know that it would be a respiratory, well, you know, it could be. I think you probably could because that person could do treatments. But yeah. But the main ones are the pharmacist, a dietitian or nutritionist, social worker, chaplain, or someone in the same faith as this person, physical therapist or occupational therapist, and any volunteers. So who would like to read the next, where it says case study progress?
I could read.
Okay.
PC confines that she has not formally written down her wishes concerning the types of treatments she would or would not want. She recommended she complete advance directives, including a living will and a medical durable power of attorney form.
Oh, good. Okay. So what's the question number 4?
How would you describe the purpose of these documents to her? Well, I know an advance directive is like a document that that has control over her healthcare decisions in case she becomes like physically or mentally unable to make a decision for herself.
Mm-hmm.
And a living will and a medical durable power of attorney is someone that takes over for her and her wishes.
Good. So a living will, documents the wishes concerning medical treatments. And that would be including the withholding or withdrawal of life-sustaining procedures, right? And I will share with you guys after, maybe I'll post it, you've all seen the new things that they talk about, the do not initiate resuscitation, and it has full code, and then it's, I'll have to share it with you, but they now have broke it all down. So when a person is filling these documents out, they have to really understand what they're signing, right? And in her case, maybe if she got to the point where she may want to not have a full CPR done and intubation and everything. She may want to just have more, suction me if I need to be suctioned, but just give me pain medication. So those are things that she would want to decide. So you said, so I can read you what they have here, but you pretty much covered it all. They have the term advanced directives describes 2 types of legal documents that let you plan for and communicate your end of life wishes in case you become mentally or physically unable to make medical decisions for yourself. So a living will lets you document your wishes concerning medical treatments, saying saying that you allow the withholding or withdrawal of life-saving procedures such as CPR or mechanical ventilation. A medical power of attorney allows you to appoint a person you trust as your healthcare agent or surrogate decision maker who is authorized to make medical decisions on your behalf. So that pretty much covered it. But they said she has not formulated, so she has not filled out that paperwork yet. Okay. Any questions on that? Just a show of hands, or has anyone filled out that kind of paperwork? I'm just curious.
I filled it out at the doctor's office.
Elise, you have? Yeah.
Yeah, and I wrote down everything I wanted and didn't want.
Good.
Yeah.
Yes, I still have yet to do that. Even after the whole thing with my dad and all of that, that is something we are going to finish by the end of the year, I'll tell you. So think about it, guys. You're all young, but it sure puts, sure makes it easier for your family if you have it done. So number 5 says, what healthcare decisions are considered in these documents? We pretty much have said that, but what healthcare decisions do you think are considered in these documents? So when they say she's got to think about CPR is one of them, but what other items?
Like
Mechanical
a feeding tube.
A feeding tube, good, yeah.
mechanical ventilation and blood transfusions,
Yep,
dialysis.
yep.
Sometimes like the refusal of medications.
Yes. So that gets pretty specific, huh? Side effects are intolerable or unwanted. The documents might be refusal. So I don't know what that would be, what kind of medications that would be. Maybe, I guess if you were doing a full code on somebody and you brought them back, you know, with all the medications and brought them back, but they really weren't all the way, you know, they end up on a mechanical ventilation and not really there. I don't know. What do you think? Nobody has a, what do you think, Nicole? Do you think, what do you think medications they would be thinking of? Indicate refusal of medications if side effects are intolerable or unwanted.
Like maybe like fentanyl or like certain opioids for pain management control.
Oh, maybe.
Maybe like
Well,
morphine.
you know, now that I'm thinking about it, I have a friend whose dad, I swear this year has been horrible, but her dad passed probably about 2 months ago. And he was an alcoholic and he had trouble with drugs in his lifetime. So he had been clean for a long time. And and he refused everything, even though even up to the end, he had like cancer of the tongue, and, you know, he was in a lot of pain. He wouldn't take anything. So I guess that would have been included in his wishes. So how are advance directives formalized then? Did you guys get to look up any of that?
You sign it and you get it notarized.
Yeah, it doesn't necessarily, well, I guess it might be from state to state, but my understanding, it doesn't necessarily have to be notarized. It just has to be signed by 2 witnesses, and it depends on the state, I believe. I could be wrong. Anybody have any?
Mine, I had to get, it had a notary where it said it had to be notarized, so I had to
You-
get it notarized.
Okay, all right.
Yeah, I think depending on the state, it can really be any 2 people. I think the state determines which 2 people are accepted. But in California, when I was in outpatient surgery unit at El Camino Hospital in Los Gatos, I and another volunteer both witnessed a client sign their paperwork, and that was accepted.
Okay, yeah, because you didn't know the person, and it was just, yeah. Yeah, it says here, I mean, I've heard it your way too, Elise, where I actually thought that you had to have them notarized too, because with my dad at the end, you know, he had nothing done. And we were like, well, how do we notarize this and stuff? And they were like, oh, you don't have to have it notarized. He just has to be able to sign it, and 2 people, not us, not family. It can be neighbors or close friends that would witness the signature. But at that point, he couldn't have done it anyway. So, okay. Anything else on that? I would say, so the answer to that is, in this particular case study, the answer that they give us is, like Nicole is saying, and Elise, it could fall into yours too. Both documents need signatures of 2 witnesses who attest that it is a person's voluntary signature. Laws may vary by state as to who the witness can be. The patient's physician, nurse, or close relative might not qualify to be a witness, which that makes sense, right? Although a close friend or close relative. So close friends or neighbors are good options, but check requirements where you live and are employed about who can sign and witness. Let's see, Virginia or Anita, do you guys, somebody want to read number 7 and answer that?
I can do that. PC states that she is confused and has mixed feeling about her health care wishes right now. She asks, if I fill out a living will, can I change my mind down the road? How should you answer this question?
What do you think, Anita? Because this is worrisome for some people, right?
Yes. Yeah, she's like on her stage, fragile stage, and she's incoherent, and her living will and advanced diet will be followed by the healthcare professional. Like she's, I would say on her.
So the question is really, let's say you have your patient and you've spent a lot of time, the palliative team comes in and the doctor and everyone, and they decide that the client isn't ready to sign something that's a no code, or he's gone ahead and signed a do not initiate resuscitation I take that back. He's still, she's still at the point that full code, she wants full code. But within a week or so, she's been in the hospital now, things have been going downhill, and no one has really addressed to her to change this full code. If she says, you know what, I don't want full code, they're asking, can she change it in the middle? Can she say, wait, no, I don't want to do full code. I want to do not initiate resuscitation. Don't intubate me. Does she have a right to do that?
I think so, yes.
Yes.
She just has to be physically and mentally fit to make those decisions, right?
Yes, and at that point, if she had appointed a surrogate or someone that could help her make healthcare decisions, that person, she would have hopefully talked to the person and said, well, if I get to this point, please have them change it. I don't want a full code. You know, I mean, when you have someone that's, you know, passing and they don't want to take that step in to say they don't want to be, they don't want to be resuscitated. That's a hard thing to say, right? But they can, it's yes. So the answer they have here and what you said is right, Anita. It's yes, you can change a living will at any time simply by telling your healthcare provider you no longer want to follow it. You can also change or modify some or all treatment preferences. This involves completing a new form and filing it with your provider. All the old copies, though, should be located and destroyed. So if maybe a family, there were a couple members of the family there while she signed her papers and they took copies home with them, once she changes this, you have to make sure they know she's changed it and not have those floating around. They should be destroyed.
Okay, so the old one will be destroyed and they're gonna follow the new copies.
And they would follow the new copies, yeah.
Okay. Thank you.
Uh-huh. So who wants to take number 8?
I'll do it.
Okay.
So as PC becomes more frail and incoherent, how will these documents guide her treatment? And basically it's that her wishes as stated in her living will or advance directive will be followed.
Yep. Yes, that's good. So now the case study progresses, it says. Who's into reading? Nicole, you want to just take that one?
So you inform PC that one of your roles will be to help with the symptom control as her illness progresses. PC relates that her primary goal is to be able to spend time with family and friends. You begin with pain control because it has a powerful effect on quality of life. And then number 9 is what interventions will you use to help her be as pain-free as possible? I said that depending on doctor's orders, you'll administer any pharmacological mechanisms prescribed. And then you will also want to use CAM therapies to supplement that. So maybe like massage therapy, hot and cold, guided imagery, things like that.
Yeah. Good. I mean, this is where the palliative team really can shine, right? I mean, being able to, if you have a really good team, being able to know ahead of time, these are the things she really wants to have happen and be able to start incorporating that in. So what interventions, so basically you already gave, you pretty much did them, Nicole. So anyone have anything else they want to add to that? To the interventions?
Maybe maintain skin integrity.
Good. Yeah. I mean, if you're able to keep her moving, massage therapy, maybe get, if she's really getting to a point in the last, where she's not getting out of bed, maybe getting her one of those beds that she doesn't have to turn a lot, but it'll still keep her skin in. She
Air
won't get-
mattress,
Pardon me?
like the air mattress they have.
Yes, exactly. What's another thing? So we're going to be giving her a lot of pain medication to keep, and well, not a lot, but you know what I mean? Pain medication is part of her everyday meds now. They may not be giving her much in the way of any other meds. So what other things should we make sure in terms of medication that she has as part of her regimen?
Probably a stool softener, because pain medications can make you constipated. And so if
Yes.
she's taking those frequently, she's at risk for it.
Yes. And actually, you know, not just the softener, but actually something that would be more of a laxative, right? So she may have a stool softener plus laxative plus fiber added to her medications. They actually call it a regimen to manage the constipation. There usually will be about 3 different drugs. Okay, good, guys. Okay, so because her advancing lung cancer will likely result in respiratory distress, which interventions should you include in her plan of care? This is those fun select all that can apply questions.
Perform a respiratory assessment at each visit.
Okay,
Have her space activities and rest as needed in a position of comfort, I think.
yep,
And if oxygen saturation falls below 90% on room air, begin oxygen at 2 liters.
okay. Good. And anything else?
I also said B, administer low dose morphine sulfate if vital signs are adequate.
Yes. Yes, why wouldn't you do the warm temperature, the room with the warm temperature and blankets, have blankets available?
You don't want to have them too hot. You want to keep them in a cool environment so they'll be more comfortable and they can breathe better.
They can breathe better. Yeah, exactly. The one thing I had a little bit of trouble with on this one was the O2. I wondered if she was at home, if they would actually, but I guess that's a comfort measure, right? I mean, because when you start getting oxygen starved, you know, you can get, have increased anxiety. And so I guess that would be. So the only one there that is not a part of the interventions would be maintain the room temperature, the warm temperature, and have blankets available. That's the one you do not pick. So Virginia, how about number 11?
Why is PC at risk for impaired skin integrity? She is becoming less mobile.
Good.
So I think that.
And is there something else that's happening that would also contribute to it?
Her nutrition, she is not getting it like
Correct.
thing.
Yep.
Better
She's probably not eating much.
than- yeah.
Yeah. So Crystal, what about number 12?
Do you want me to read it?
Yeah.
Okay. Realizing that loss of appetite often accompanies the dying process, describe how you can maintain PC's oral nutrition and hydration. I would say like she should be given small bites of soft food like periodically. Also she could be given like medication to increase her appetite. And she should adequately rest before her food time. And if she refuses, then she can be given like nutrition, like IV nutrition, like vitamins, minerals, and stuff like that.
Or NG, right?
Yeah. Mm-hmm.
So remember, that's only if she had agreed to it in her.
Yeah. Mm-hmm.
Yeah. Good. So why do you think performing regular mouth care would be something you might want to have happen? Regular, mouth care.
Because dry mucous membrane can like cause injury or can build up some bacteria.
Okay. I like the thought about injury too, right? I mean, if she starts getting sores in her mouth, or anything like, then you could end up, she's not going to want to eat or swallow anything, right? So yeah, keeping her.
And we would want to like explain to her that it will help her be to taste her food better, maybe.
Good. So do we how do I put this? So you just let her pretty much eat what she wants, right? You try to make it the healthiest of whatever she wants to eat, but you're not going to force her to eat anything, right?
Yeah, I said have her eat and drink whatever she can tolerate.
Right. Okay, so who wants to do the next one? 13.
I can do it. So number 13, toward the end of your visit, PC looks at you and says, I just really thought I had more time. The most appropriate response is, and I said, see, tell me more about what you mean when you say, I thought I had more time.
Perfect. Yep. So why do you think that works the best?
That allows the patient to describe in their own words what they're feeling, and it kind of opens the door for them to express how they're handling their diagnoses, and you can also evaluate them like how they're handling it psychologically and emotionally.
Right. Anyone else? Why wouldn't you say dying is a natural process? We will help you through it.
It like, to me, it sounds like how Nicole said. It just sounds like an open and shut thing. Like you're not really listening to what she's saying. And to me, it feels like right now her words are the most meaningful thing she has. So I think that she should be able to express herself instead of just like shutting her down.
Good. What about, because these questions can be hard, right? Because you read them and you're like, well, you know, you read each one of these and you think, well, yeah, I could see someone saying that or that. So I like the way Nicole described that in Claudia said, basically, always think about validating the client or the patient's feelings in their words, and just be there to listen. Okay. So who would like to take 14?
I'll do it. You are concerned with PC's psychological status, particularly because she's expressing feelings of grief. Write a nursing outcome addressing this issue. Identify independent nursing actions that you would implement to provide her emotional support.
So do you understand what they mean by when they say write an outcome statement? Because I had a question like this on the last test quiz. So basically when you see outcome, think of goal. So what is your ultimate goal for her? And so write a nursing outcome, write a nursing goal that addresses this issue, and then talk about some interventions that you think that could help meet that goal.
Would you be able to give me an example, like
Of an outcome?
of a nursing outcome?
A nursing outcome. How about, so an example they put here, which it looks pretty good. Say client will work through stages, let's see. The client will be able to work through stages of grief, expressing emotions and verbalizing their needs. And then you would put your interventions to help them do that. Do you have some ideas?
Would like an intervention be like how we, when she stated, that she thought she had more time, like just listening to her, like
Perfect. Yep.
allowing her to express what she feels?
Yep, exactly. What else?
Encourage family to like be there for her, to support her with her needs as well.
Yeah, yes, because they're going to help her work through stages of grief, right? But you're also helping them work through their stages of grief. So that's good. That helps the client or the patient work through it. You got a couple more in there? So we have listen to her, allow her to express her feelings, to talk, to cry, to be angry. And I like this, name the emotions she's expressing. So give her that name so she understands, what's going on. And you said, encourage the support of family and friends. What are a couple other ones? No. Do you think, what about as her nurse, if she says, so if she says, or if the family asks you how, just one second, get out. No. If the family asks, how long do you think she has? How should you respond? And I'm not talking about specific words, but how should you try to respond to them?
You just have to communicate as like honestly as you can, because you don't want to lie to them.
Right. Right. You want them to be able to, you know, trust you. They're trusting you with this, you know, this very important time in all of their lives. So to be open and honest with them is going to be the best strategy, the best intervention. And it also would help, yeah. But what else do you think? I mean, this is a woman who, I mean, when I read about her, she is, I mean, let's see, they said she's 64 years old. Guys, that's not that old. And she's a divorcee, so she's probably lived on her own, done her own thing. They don't say how long she's been divorced, but you know, she's pretty much taken care of herself, it seems like. So what do you think would also help?
So not let her alone.
Not let her alone. Yeah, I agree. What I'm trying to get to is basically helping her to understand there are some things she still has control of. Right?
That's what I was gonna say. Yeah, like if she, if there's like certain things that she would like to do,
Yeah.
right? Like that we are able to help her with, maybe.
Yes. Yeah, and maybe she wants to go to the park still, or maybe, you know, she just wants to sit out in her chair out in the backyard, or you know what I'm saying, that those things might still be in her control to do with a little bit of help, but she can still do that. In what decisions that she can still make on her own, you know. And then there's one, let's see. Well, one of them is just offering continued support as you as her nurse, that offer the continued support and that you're available to her over the course of the time that you have her as your patient. And there is one thing that I think towards the end of life, I don't know, sorry guys if I put this in a but I guess encourage, you know, think about spirituality for the person. And it doesn't necessarily have to be how you personally think of spirituality, right? It can be whatever they think would meet that need. Does that make sense?
Yes.
Okay. So anyone want to add anything more to that? So this is your patient. She's starting, you're really concerned about her psychological status. And you're really concerned that she's having trouble working through her grief, her stages of grief, and trying to express emotions and to talk about what she needs done or needs. and you're thinking about interventions, things that you could do for her. I mean, I think you guys we talked about a lot of them. I'm just wondering if you can think of anything else.
Maybe she could go to like a group of where other people are going through the same thing as her, and like she can relate to them and they can relate to her, and I don't know. So she won't feel like she's alone, even though she might have like our support. She still might feel like, but you don't really know what I'm going through.
Right. Right, depending on how early on she starts talking about this, right? But you're right, there are support groups out there. So anyone want to read the case study outcome?
I'll just read it since I'm unmuted. PC discusses her wishes with her family and completes the documents describing what she would like her plan of care to be over the rest of her lifespan. She dies peacefully 7 weeks later in her home, supported by her family and friends on her terms.
That's nice, right?
Mm-hmm.
So, did anyone want to add anything more to this? My plan is I have a PowerPoint that I'll put together. I'm thinking about maybe just recording it tomorrow, and so that you guys have it. Does it help for me to record it, or is it just like post it, Mrs. Thorpe? We don't need to hear you talk about it.
Just post it.
Just post it.
Because sometimes the recordings don't record.
No,
Or they don't like get posted until super late.
Yeah.
I'm sorry, Nicole, what?
Sometimes the Zooms take forever to actually post. So like we can't access them for a while until it's like,
Not my Zooms. My Zooms are up that day, that night.
okay. It might be different if you like pre-record and then upload it, but I know like when Miss SB does her lectures for farm, or when Miss Skifford was doing the other case studies, they like took a while to finally upload and be accessible.
Yeah, just shoot me if I ever do over an hour and a half. Sorry, yeah. No. I think an hour Zoom is max. I don't think that it's helpful after a while. But I think so for sure I'll put on, but I really have tried not to, and I put them. That just tells me you guys haven't done my Zooms. You haven't listened to my Zooms.
I'm going to be 100% honest. I usually just look at the PowerPoints.
Okay, that's all right. That's all right. Okay, that's fine. No, I actually enjoy better having you guys come online and talking about the case study. And I don't think it needs to take us, 2 hours to talk about the case study typically. So, I mean, this is a pretty short one, but so, all right. Any other questions that you want to go through? You guys, so we have an exam this Sunday that'll open at 5 o'clock like we've been doing. It is an exam. That's number 3. So
Sorry to cut you off, but I don't know if it's possible, but if you can do this, I would really appreciate it. And like, could you keep the essay questions together? Is that possible?
Oh, you want them together?
Yes, because that threw me off. It threw me off a lot because I was like trying to rush through them so I can get to my question ones, and then I ran out of time and my questions were towards the end.
Okay, so don't put the essay questions at the end or put them at the end?
Well, mine were scattered, like, and I like how you did it the first time, like you opened it with the essay questions and they were all together. But this time on my end, I don't know if everybody's was the same, they were scattered. It was maybe like 5 of the normal questions and then a random
Yeah, okay.
question, and then I was like, that's how I lost track of time and I didn't get to finish my exam.
Oh, okay. No, that makes a lot of sense. I'm gonna, if you hear my dogs, they're being pills all of a sudden. Anyone else have that problem? No? Okay. But that's a good point, Claudia. I know that there are people who are having trouble. And then the other thing is, I was speaking to someone last week. I think we went over a few things and just talking about if you hit a question early on and you see that, oh my gosh, this has really thrown my, you know, I it's like a question you see and it's like causes panic.
Yes.
Like reading another language, you have no idea what they're asking. Spend a minute or two on it. If you don't get it, it's 2 points, move on. Don't let it don't be, because I was talking to a couple people and they're like, yeah, I was spending a long time on that and it really threw me for the rest of the test. Think about it. It's really only worth 2 points. If, move through it if it really has thrown you. Okay. Now the essay questions, yes, Claudia, I will see what I can do about putting them. I think what I tried the last time was put them with the, like, let's say I'm going to do an essay question on palliative care. I was trying to have the essay questions.
Oh, like on the same topic?
In the same section, but I don't know that the way Canvas is doing it, if it keeps it in there. Maybe I'll have to look at it. I'll take it, you know what I mean? I'll run through it, preview it and see what it does. Okay, but that's a good suggestion.
Thank you.
So as long as they're together and
Yeah.
you prefer them at the beginning.
Mm-hmm.
And remember on these essay questions, I'm only looking for like.
Yeah, you said like 4, like 4 to 5.
4 sentences. I'm looking really for some like specific wording is what I'm in. And really, if I see that, yes, you're thinking along the right lines, I give you the points for it. Okay. But I'm looking for, because obviously you can't write specifically what I put down there, but as long as you're in that same direction, I usually try to give you points. If it's, I had a few that really missed it altogether, I still try to give you guys points because I know it's worth a lot of points. So I try to do like maybe 1 to 2 points, so, all right. I think that's it for me if you guys are good.
What topics are going to be on this next exam? Is it just everything from the end of the last exam up until this week?
Yeah, let me go real quick, Nicole, and I'll tell you what I put down. Let's see. So it's going to be on weeks 9, 10, 11, and 12. So what that covers, and I'm going to have 15 questions in each week. And right now we said 2 essay questions per week. Last time we ended up, Mrs. Gifford's like, I didn't give them that many essay questions. But we have to have so many points. So that's why we end up giving you the essays. So if we cut out an essay a week and we only have 4 total essays, then that means we have to come up with you know, probably another 20 questions total to answer. Okay, so, and then so basically what that is, it's going to be the acid base balance, elimination. And what I've done so far, let's see, caregiver, and then, what was it? Sensory perception was the one Mrs. Gifford did. So like, for example, in the caregiver one, I really have tried, I'm trying to get better at this, of really attaching, at least having, like, let's say you have 10 objectives, at least having 10 of those questions directly attached to that objective. You know, one question. Does that make sense? So really go back to your objectives. And then look at the, remember to look at the case studies. Now, that being said, let's say, for example, we have a case study on cleft lip, the one 60 cleft lip, the nursing care for cleft lip, a baby with cleft lip. But there may be a question that isn't directly to that specific case study, but it's on coordination of care for a baby with cleft lip. Does that make sense? Look at healthy people 2030 for the aging population. Specifically, remember dementia, Alzheimer's, that kind of stuff. Okay.
Ms. Thorpe?
Okay.
Yeah. Yeah.
For the next proctored exam, which is nursing care of children, will we have any practice exams on ATI like we did with fundamentals and maternal newborn, or should we just study the book that we got as part of our kit?
Say that was for the nutrition one. Is that what you said?
No, for the next ATI proctored exam, I think it's like December 1st, nursing care of children. I was just wondering how to best prepare for that.
Here. I'm going to say right off, yes, I would do the ATI book on nursing care for children. Did you already do a nutrition one, or was that included in the maternal child one? Or
I know we have like a separate book as like part of our bundle for nutrition, but as far as proctored exams this semester, we just did fundamentals, maternal newborn, and then nursing care of children, the next one.
So I would also take a look at the nutrition one, specifically focus in on those items for kids.
Okay, because I know like the nursing care of children book, I think is slightly bigger than maternal and newborn. So I think it's a little bit more info. I just wasn't sure like what specifically you focus on.
You know, it's hard because they don't give us anything, but let me put out, I'll put out to Mrs. Espy and Mrs. Gifford and say, you know, is there any practice exams for nursing care of children? And we'll see what they say. I'm sure they would have already just told you, but let's see. I'll put it out and then I'll let you guys know, okay?
Okay, thank you.
Okay. All right. Is that it, guys? I'm going to be here at home doing stuff all day tomorrow, working on grading. I got to get all your gradings done. I have so much grading to do. So that's my plan for tomorrow. So if you need something, just shoot me a Google Hangout or an email and we can do Zoom or something. Friday, I'm gonna take half day on Friday and I'm taking Monday off because we are doing my dad's celebration of life on Sunday and that'll be here at my home. So that was my plan. Okay. Is that okay? You guys-
Yeah, okay.
Yes.
Thank you.
Okay. All right. I'll shoot you back on Google Hangout if I find something tonight about anything more to study.
Okay, thank
Okay.
you. Ms. Deb.
Mhm.
Okay.
Bye.
Okay. Bye, guys. Have a good night.
Good night.
Good